सर क्या हाल है मुलाजिम साहब, खैरियत है?
सर क्या हाल है, ठीक है सर?
बिल्कुल अल्लाह का शुक्र है।
जी अल्हम्दुलिल्लाह, थैंक यू सर।
अस्सलाम वालेकुम जी।
वालेकुम सलाम प्रोफेसर।
वेलकम सर सरवत साहब टू पाकिस्तान।
प्रोफेसर साहिबा क्या हाल है आपके? आप खैरियत से हैं?
अल्लाह का शुक्र।
हम आपके वालिद बुजुर्गवार के शागिर्द रहे हैं।
अल्हम्दुलिल्लाह जी, बस दुआओं में याद रखें उनको जी। सर किधर निश्तर में या कई में?
नहीं जी, केई में मैडम, केई में।
जी
नाम से शुरू जो निहायत मेहरबान।
जी बिस्मिल्लाह शुरू करें।
जी हम वी आर वेटिंग फॉर
राशिद
समवन।
साहब तिलावत कलाम पाक करें। प्रोफेसर राशिद साहब तिलावत कलाम पाक।
जी बिल्कुल जी। औज़ु बिल्लाहि मिनश शैतानिर रजीम, बिस्मिल्लाहिर रहमानिर रहीम। वल अस्र इन्नल इंसाना लफी खुस्र इल्लल्लज़ीना आमनू व अमिलुस सालिहाति व तवासौ बिल हक़्क़ि व तवासौ बिस सब्र। कसम है ज़माने की, बेशक इंसान घाटे में है, सिवाय उन लोगों के जो ईमान लाए और नेक अमाल करते रहे और एक दूसरे को हक की नसीहत और सब्र की ताकीद करते रहे। सदक़ल्लाहुल अज़ीम।
जज़ाकल्लाह। आज का सेशन शुरू करने की इजाजत चाहता हूं मैडम। प्रोफेसर सलमा कुंदी हमारी पीएमए की प्रेसिडेंट है जी। कोरोना पिछले पौने 2 सालों से पूरी को अपने लपेट में ले चुका है। पूरी दुनिया को अपने लपेट में पिछले पौने 2 साल से ले चुका है। और उसके डायग्नोस्टिक टेस्ट जहाँ पे पहले पीसीआर होता था, लेकिन जैसे जैसे कोरोना के वेरिएंट बदले उसमें पीसीआर की वैल्यू एफिकेसी कम होती चली गई और बहुत सारे लोगों को तशखीस के मराहल में दाखिल होने के लिए सिर्फ एक जरिया रह गया और वो था रेडियोलॉजी और एचआरसीटी। आज उसी सिलसिले में इतने मसरूफ मुल्क में रहते हुए और इतनी गुनागो मसरूफियत के बावजूद अपने मुल्क के लिए उन्होंने टाइम निकाला। बुनियादी तौर पे MBBS हैं, इसके बाद उन्होंने FRC किया, इसके बाद FCPS किया। आजकल प्रोफेसर ऑफ रेडियोलॉजी ऑफ University of Massachusetts Medical School and radiologist of Richmond, Virginia Medical Center, Richmond, United States of America हैं। He was also the founding person, chairman of the Aga Khan University, Karachi, and founding chairman of Imam Ali Khujah Hospital, chairman King Faisal Specialist Hospital, and chairman Urey Clinic, United States of America. He has served at Harvard Medical School, Boston University, University of Massachusetts. He has published more than 150 abstracts and around about more than 80 original papers, so many chapters and books, and reviewer of the books, and launched a journal of global radiology, and he established the Global Institute of Health, HQ. Professor Sarwat Hussain was awarded Colonel Memorial Medical of Kingwood Medical College, Lahore. He was once selected as a vice chancellor, but he denied to. He received the Humanitarian Award of the American College of Radiology. Professor Sarwat is the teachers of the teachers. I am honored, Professor Sarwat, आपने हमारे लिए वक्त निकाला और बहुत सारे सवालात ज़हन में हैं कि HRCIT वो क्या ऐसा जादू है जिससे वो कोविड के नमूनिया के बारे में बड़ा डिफरेंशिएट।
I think we have an audio problem. Assalamu alaikum, everyone.
Walaikum salam, sir.
Thank you, sir, for your very kind introduction. And in fact, you are the teachers of the teachers and the examiners of the teachers. How many professors you have encouraged and guided to through PhD program that you had started. So I think Azad Kashmir Medical College is very fortunate to have a giant like, not physically, but a giant like Professor Mulazim Hussain, who is a legend in his own right in the country and abroad, mashallah. And thank you for being talking to such a august, and frankly, I'm a little bit intimidated by such big names in medicine, like Professor Bilqis Shabir and Professor Mulazim Hussain and Professor Rashid Mahmood. So without taking too much of your time in the formalities, I'm going to start and share my slides and see if I can share them. Let me, I think I can share them. And can
yes,
everybody see this? Okay. Bismillahirrahmanirrahim.
Yes.
Thank you, sir, again very much. So Professor Mulazim Hussain asked me to talk about, he gave me a topic of role of radiology in the diagnosis and prognosis during and post-COVID-19 pandemic. And I considered Professor Mulazim Hussain's message as an order for me. So here we start. I just want to start with this slide and ask everyone, it's a trivia question. I've asked everyone, what is the relationship of this teaspoonful with the numbers on the screen? Anyone, just to make it interactive and a little bit of fun, can anyone guess or tell me what these numbers are and what a teaspoonful is?
Both cannot be counted.
Okay, very good, excellent. Well, the number of 23 crore 15 lakhs 61,671 are the number of coronavirus patients to date in the world, and out of which 47 lakh 45,154 deaths have occurred due to coronavirus. And if you were to put all the coronavirus that caused this disease and death will be equal to 1 teaspoonful, which means that the virus is so small that it is amazing that this teaspoonful has caused so much havoc and continues to cause disease and deaths in the world in various forms. And as you know, the history really starts in December 2019, when one of the strains of coronaviruses came out in December, and therefore it was given a name, December 2019, and therefore it was given a name of coronavirus Covid-19 2019. And primarily, the virus affected the respiratory mucosa and vascular intima. And if you remember the early 2020s, we heard about people actually dropping dead in the street in China. And then everything kind of hell broke out in the world. And all the history, which I don't need to go into. But any lecture, any discussion on coronavirus, since it's a live pandemic, will not be complete without defining the risks of transmission, and also not only in public life, but also in healthcare, because transmission of disease can occur either through patient contact in the medical care settings, via the equipment. If you bring an ultrasound machine or X-ray machine or ECG machine next to the patient, and transporting the patient from one place to another and spreading the germ. And therefore, it is still very important for all of us to wash our hands frequently for at least 20 seconds, use mask ourselves and never to let this precautions go, and also make sure that the vaccination takes place to ourselves, and that we propagate the value of vaccination to anyone who we get in touch with, because all this information and knowledge that we're discussing will be useless if we are not there to practice and preach to the others. We know that the coronavirus replicates by invading a cell and making the cell into a virus factory. In itself, the coronavirus is not capable of replicating or producing more children of itself. It requires a human cell, or any living cell for that matter, where a small little virus enters into the cell and replicates inside. And there's a whole pathogenesis of replication that we will not talk about. Over here, virus actually sticks to these little receptacles, if you will, on the cell, and hundreds and thousands of virus are produced. And primarily, as we know, the coronavirus primarily affects the lungs, and it affects the lung mucosa, and it also affects the blood vessels of the lung. The alveoli are affected, and therefore the alveoli gets filled with fluid, the exudate and the transudate, mostly exudate, and replaces the air from the alveoli. Therefore, the oxygenation and air exchange cannot take place, and the patient will have almost like asphyxiation in the sense of oxygenation stops. The second complication, which can occur, although not as common as the lungs, is the endotheliitis, where inflammation of the endothelium of the pulmonary vessels causes thrombosis and embolism in the vascular tree. And to a lesser extent, depending upon the risks factor in a patient, the thrombotic phenomenon or embolic phenomenon, actually it's a thrombotic phenomenon, can occur in brain, in GI, in kidneys, in heart, and leads to multi-system failure. And if it does not kill by lack of oxygen from acute respiratory distress syndrome, ARDS, it kills by multi-system failure. Now, I know that Professor Mulazim stated that HRCT is a diagnostic tool, but I'm here to tell you really that HRCT or chest X-ray is not a tool of initial diagnosis. And we know that in the early stages in Wuhan province, before any PCR test or other tests were developed and invented, developed for the purpose of diagnosis of COVID, you did diagnosis through CT scan, and high resolution CT scan does produce certain images that we will share with you. But as the diagnosis, prognosis, and treatment has evolved, it is not considered, imaging is not considered as the modality of diagnostic initial diagnosis. However, it has a strong indication and application for symptoms-based diagnosis and prognosis, complications, assess the progress of disease, judge the prognosis, and take the diagnostic and therapeutic decision and follow up for chronic complications to see again for the progress and prognosis. So as we said, CT imaging is not that of initial diagnosis, only in the symptomatic patients when the symptoms have started, or when the symptoms change if the patient is admitted in the hospital. As we know that in emergence in the ICU, portable chest X-ray is recommended on a daily basis, but in case of COVID, chest X-ray is recommended only when clinical indicators change. For example, the oxygen level changes or patient's situation change. And so it has also been the chest X-ray finding and the CT findings are such that up to half or 56% of chest X-ray are normal within 2 days of confirmed cases in the beginning. This number varies from place to place, and also, of course, the confirmation of cases may not actually occur within 2 days of infection in the patient. As we know, it might take several days before the clinical features appear, but nevertheless, chest X-rays are normal in majority of patients. But converse is also true, that in many patients, the chest X-ray may be positive while the patient is totally symptom-free, and may, in fact, in those small number of cases, be the first sign or clinical presentation of COVID-19. So while there is so much uncertainty about the chest X-ray finding, therefore we recommend especially in this day and age when there are, in these days when there are better ways to confirm by PCR and other means. And similarly, the most extensive changes will occur in chest X-ray on 10th to 12th day after the onset of disease, which corresponds with the clinical peak of the clinical features in COVID-19. In the CT, 5 to 8 days, there is the CT appearance of the pulmonary findings occur early on, even earlier than chest X-ray, but they increase in 5 to 8 days. And as we understand, 9 to 13th days become more extensive, become consolidative, and they correspond with the clinical stage, as we said before. By 2 weeks, by about 14 to 15 days of the onset of confirmed cases, there is absorption of the fluid in the alveoli, and the resolution occur relatively quickly in the largest portions of the findings in the lungs. So here are the two X-rays. The one on the right is the CAT scan. This is the CT scan coronal reconstruction. And I'm demonstrating this with ease of comparison with the CT scan to demonstrate how better the high resolution CT scan can demonstrate the CT finding, which may be in fact easily detected by our clinical colleagues, non-radiologists. But on chest X-ray, very hazy increase in density, which corresponds, this is the same patient, which corresponds with the density on the chest X-ray and on the CT scan. And therefore, it needs experienced radiologist or comparison with previous normal chest radiograph to detect these abnormalities in the diagnosis of COVID. The progression of disease occurs, it kind of starts with early ground glass appearance. Ground glass means that it is like a Milky Way bulb that you use, the not totally transparent, but the light can emit through. This is ground glass appearance is the hallmark of opacities in the CAT scan as well as on the chest X-ray. And this is different from pneumonia or consolidation, where the affected area is totally complete and you really cannot see through these opacities. Over here, there are opacities, but you can see through these opacities other structures, and therefore these are called ground glass appearance. And the progression of disease occurs in 5 to 8 days to appearance like this, and we will see these kinds of images a little bit later on also, until it progresses even further. And when the disease occurs, affecting most of both of the lungs, at this time, the patient requires intubation and a high risk of death. Therefore, the role of chest radiograph and CT scan is to determine or anticipate when the patient is going to require endotracheal tube in the ICU, or maybe admitted to the ICU before the clinical feature compel you to take those actions. And similarly, sometimes the chest X-ray and the CT scan in conjunction with the clinical features will guide you to admit a patient from an otherwise outpatient situation or emergency department situation. So therefore, there is the indication of action that you're going to take before the compelling features of the clinical findings occur. So here is the progression of disease. On the 4th day, chest radiograph shows that there is faint findings of the opacities on the X-ray on the far left on the 4th day. On the peripheral opacities, On the 6th day, those opacities has become larger. And on the 11th day, both lungs are now patchily opaque. And you can see an endotracheal tube in the trachea because of increased opacity and limited oxygenation. The findings are actually clear. And also, as we said before, there is endothelial inflammation, and endothelial inflammation causes thrombosis to occur, and there are opacities and filling defects of filling defect of emboli. These are not actually emboli, these are actually thrombi, because these are not the ones propagated from the veins of the leg, but these occur locally because of inflammation of the endothelium. And as the arrows point, the yellow arrows point to presence of filling defects in a contrast enhanced pulmonary emboli. My pointer is really not working on the screen for some reason to point to, but nevertheless, the yellow arrows are point to the filling defect of the within the pulmonary system. Now, in order for the clinician's colleague to make a decision as to prognosticate or anticipate the clinical condition of the patient, disease severity score or objective score of calculation have been attempted and successfully used both on chest X-ray and CT scan. And basically what it indicates is the percentage of lung that is affected and is not available for oxygenation. And we know from our practice even before COVID that if you divide a chest into 6 zones, upper, middle, and lower of both lungs, if the patient has a healthy lung and you lose 3 zones in the chest X-ray, the patient is not dyspneic on light exercise. If you lose 4 zones, which means whole of one lung and 1/3 of the second lung, the patient begins to get breathless on even mildest exercise. If you lose 5 zones, which means whole of the lung and 2/3 of the other lung, then the patient is breathless at rest and will require supportive treatment in order for to sustain the oxygenation of the body. So that has been known for a long time. Taking that into account, severity score have been calculated in the lungs from various methods in order to quantify the part of the lung which is out of commission, if you will, from oxygenation of the blood. And these are visually judged patches of consolidation, which are assigned score in order to assess the severity of the disease into mild, moderate, or severe. Other than assigning the score by visual method, there is artificial intelligence method by vision transformer method, in which the lung abnormality is automatically evaluated and assigned a score, again, to give a score of mild, moderate, or severe. So this is the method. Lungs are divided into 3, or by another method into 4 zones, and by another method on CT by the segments of the lung. But nevertheless, the idea is that there is inter-observer uniformity of the lungs, so that if I look at the lung and I describe a score of 16, for example, or 10 or 4, depending on the method, that the next radiologist, the next clinician, and next physician is able to relate to that score and see whether the follow-up X-ray, the score has increased or has reduced. And that gives us the appearance, that gives us the scoring system. Here's an example of a scoring system where the light yellow patches are ground glass, while the dark yellow patches are consolidation. And you score according to these given on the left of the slide, the ground glass score and the consolidation score. And when you put them together, you tell that is the total score. And there is an understanding that beyond a certain score, patient will require hospitalization, and after a critical number in the score will require oxygenation, and beyond certain score, death of the patient is very likely. Therefore, prognostication can be done. Similarly, the severity score on CT scan, again, grade 1 is no detectable disease. Grade 2 is a single ground glass lesion in one lobe. Grade 3 is bilateral multiple ground glass lesions. Number 4 is confluent ground glass lesions and consolidation. You see the difference very clearly in this image. The ground glass changes and the consolidation changes. Consolidation is totally opaque, ground glass is semi-opaque. And number 5 is confluent lesion involving more than 50% of the lung parenchyma. And on CT, this is how the severity score is done. I'd just like to add here that the indication of CT scanning or chest X-ray is really not absolute. It all depends upon the resources available, and there is no need to overwhelm a CT scanner if there is one CT scanner in a large number of patients requiring it. That chest X-ray with expert radiologist or physician, expert physician, is good enough to follow the patients. In our society in Pakistan, we tend to give the high resolution chest CT, reserve it for the VIPs, and chest X-ray for other affording patient, and no imaging for non-affording patient. This is all I think is a social imperative in medicine rather than medically indicated. So here is the progressive chest radiograph that demonstrates how the patient deteriorates. And when you come to the image number H, you know, or even if for image number G, you know, the patient has a greater chance of requiring endotracheal tube, and many of these patients will probably die. So here is a study of 572 patients in whom there was correlation between the severity score and the patient outcome. And there is a reasonable correlation between the severity and the patient outcome. 70% of the patient who had severe disease based on the severity score either ended up in ICU or died, and this score on CT scan. And similarly, 41% of moderate disease and 23% of mild disease ended up in ICU or died. And so this is the benefit of quantifying the abnormalities in the lungs on CT scan, and similar results are for the chest X-rays. Here is an example of chest X-ray positive cases in a study of 134 patients where the score from 1 to 8 was assigned, and 1 being negative and 8 being, of course, the highest. Then you notice that the 56% of patients had the highest score from 1 to 4, and they had a mortality of 8%. while patients with a score of 5 to 8 had the mortality of 24.4%. And similarly, the ICU admissions for a lower score were less frequent, about 1/5 of the patient, and for higher score were 44% of the patient. So the severity score is a good indicator, and I believe gets the maximum out of the imaging and for the purpose of management of the patients clinically. Now, so to recap, the quantifying the or severity score or quantifying the disease will help in making a decision about hospital admission when the patient is ready to be admitted or should be admitted, even if the evident clinical presentation may not be as severe, but chest imaging, X-rays or CT scan will tell you beforehand that this patient is going to require admission. Similarly, intubation, and then also tell you the course of the disease and the prognosis in terms of whether there are changes in the chest X-ray or CT scan towards betterment, because the clinical presentation lags behind the radiographic presentation. And a radiographic presentation occurs early and clinical presentation later. And that is the advantage we can take in determining as to what is to come. And also, these comparisons will tell us about efficacy of treatment, if the treatment is working and patient is getting better or not. So it is independently, imaging is not as useful as it is, and taken in conjunction with the clinical features and the expertise of the treating physician. Everything put together helps in the better outcome of the patient. Now, it is not only the lungs that the coronavirus affects. Here is a 22-year-old patient with COVID-19 and chest pain. And this is a contrast enhanced MRI short axis image of the heart. And the arrow points towards posterior left ventricular wall. And the patient's demonstrates that the crescent of increased enhancement along the arrow indicates contrast enhancement of this wall, indicating ischemia. And in a 22-year-old patient, the ischemia, of course, will be secondary to vasculitis or intimal inflammation of the coronary artery supplying this segment of the heart, leading to ischemia because there is delayed accumulation of gadolinium in the myocardium. There are other non-thoracic complications of COVID-19, which are all related with vasculitis, leading to thrombosis, leading to ischemia. As you notice on the picture on the left, there is a high signal MRI of the brain, shows high signal area in the right occipital bone, and this was hemorrhage secondary to infarct in that area, again secondary to vasculitis. So this is an hemorrhagic infarct. Next picture is the coronal section of the abdomen that demonstrates ischemic changes in the small intestine, and there is small amount of air in the portal vein on this coronal CT scan image of the abdomen. The next image shows an area of coronal image of the kidney, left kidney, in which there are areas of reduced enhancement of the renal parenchyma. Normally, the kidney should be uniformly opaque after contrast, and the arrows indicate the areas of reduced vascularity, and these are renal infarcts due to vasculitis of the supplying arteries inside the kidneys, the arcuate arteries that supply the cortex of the kidney. And similarly, there is vascular changes on the image on the right, vascular changes in the liver, giving rise to these image findings. Now, since Dr. Bukhari has requested the prognosis and the late appearance of the COVID-19, now here's a patient in the top two images was about 6 weeks following the resolution and complete recovery from COVID-19 disease, but there is what looks like a lot of interstitial lung markings with small amount of lung opacities. And this suggests fibrosis in the lungs. And this can continue for a long time if untreated. But in this patient, the patient could not walk more than like 30 feet at this time. Steroid treatment following 2 weeks of steroid treatment, and the image below, the two images below are after treatment, and was able to walk a mile after the treatment. So the chronic changes subacute changes do remain in the lung, but they do respond to timely treatment. Very rarely, these patients will end up having chronic fibrosis, like in this case, honeycomb appearance, kind of typical and not differentiable from the interstitial lung disease that you see in cryptogenic interstitial lung disease, and they may they may suffer from changes and the restrictions of the chronic interstitial lung disease. But the history of the disease is not such that we really don't know how this fibrosis will behave over several years, whether it will resolve itself or whether the fibrosis will become worse, or whether it will remain the same, and other measures can be taken to improve the patient's health. Now, while we were talking about the hand washing and the mask and the COVID vaccination, there are other factors that lead to not only the lung fibrosis, but also affect the prognosis of patients, require early intubation, early hospitalization, and early death. And those relate to the comorbidities of the patients. And the comorbidities, as we know and expect, and probably everybody knows that patients who are obese, who are hypertensive, who are suffering from diabetes or chronic liver disease or chronic kidney disease, HIV, sickle cell disease, asthma, COPD, and pre-existing interstitial lung disease, any of these comorbidities will increase the severity of disease, will resist improvement on treatment, and may actually cause death. So the chest X-ray and CT finding alone is not the prognostic indicator. The indication of more complications and higher death rate are accompanied by or caused by these comorbidity. Indeed, which is the case in any acute situation. And there are certain cutoffs in the age as well as the BMI in terms of obesity. And of course, smoking is a ubiquitous risk for human beings in any and all disease conditions. Thank you very much, ladies and gentlemen, and I will be happy to take any questions. And thank you very much once again, everyone. And thank you to Professor Bukhari. Thank you.
Thank you so much, Professor Sarwat. Professor Sarwat Kundi is President Pakistan PMA. And I will request Professor Kundi to ask a question to start this question and answer session. Professor Kundi.
Okay, Ji. Thank you, Dr. Sarwat. It was a lovely talk. I really enjoyed it. And it has increased knowledge about X-rays and CT scans and obesity. I really don't know what to do with our obesities. I hope we can easily lose some weight. The floor is open for question answers. If anybody has any question to ask. I noticed Zishan Rahman from Ireland in the list. Zishan, do you have a question to ask? Or anybody else?
Hello everyone, Zishan Rahman here. It was an absolutely brilliant lecture. I really enjoyed it. Explained everything really well, working on a daily basis with COVID, on COVID wards here. I work in Birmingham at the moment. It's absolutely amazing. It increased my knowledge on seeing radiological pictures on a daily basis. Really helpful. Thank you very much, Dr. Sarwat. I really appreciate it.
Can you please mute your mics if you're not talking, because we can hear Azan and it's disrespectful. Professor Bilkis, you want to ask something?
Yes, if as a host you could mute everybody, and because and then as a host you can mute everybody, and then Sarwat Saab and myself and yourself can unmute.
Wadid, can you mute it?
I think Alhamdulillah, and thank you so much, Professor Sarwat Saab. It was, I think, it's difficult to describe how interesting your lecture was, how absorbing it was. I have this congenital anomaly of not being able to concentrate in any lecture for more than 10 minutes. But yours was so interesting. It was, sort of interactive, and the way you started off and the slides you showed were very easy for us non-radiologists as well. And besides that, they were very, very practical. Sir, I would just like to share a little experience of what we are going through regarding COVID in Punjab at King Edward Medical University, and Mayo Hospital is the biggest center in Punjab as well as Pakistan, which is catering for maximum number of patients. Right now we have about 190 patients in the COVID ward. All are the severe patients we are admitting now, all on high flow oxygen. So either it's a non-rebreathable mask, or it is BiPAP or CPAP, nothing less than that, and very few who are intubated. We generally avoid intubation in COVID because of a poor outcome. So this, as Professor Mulazim started off, radiology has been a big backbone as far as the diagnosis of the disease is concerned. The reason is that it does take some time for the labs to come back, for the PCR test to come back. So many a times it's the clinical picture and the radiology that we are depending upon. And the pictures you have described, without your permission, sir, I would like to seek permission. Following doing what I did, I took pictures of your very, very informative slides and shared on my East Medical Ward group for my students. And while I was doing that, I can see about 10 of them who have joined. So I asked permission for copyrights to share those pictures, and they were very, very beneficial.
Madam,
Sir,
I will send you the whole. I will send you the whole talk if you
that would
wish. Yeah.
That
Yes,
would
ma'am.
be a huge honor. And sir, if we could, have another session with you
Yes,
at the
madam.
forum of King Edward Medical University, it would be a huge honor and very, very, appreciative. Sir, there's just one. You talked about the acute picture. You talked about the post haulers and the chronic fibrosis we are seeing in the patients, and that is very much matching with the clinical presentation. They come up with prolonged periods of dyspnea, fatigue, and lethargy following the acute episodes. We find the markers are going down, but radiological changes do not set in. So my question is that since we have gone through this disease for about 1.5 to 2 years almost now, what is your observation on the whole that does this eventually settle? Because this is a question which they ask you कि डॉक्टर साहब ये ठीक हो जाएगा, ये जो चेंजेस आप धब्बे बता रहे हो ठीक हो जाएगा. And in Pakistan, since this disease first came on the 26th of first patient came on the 26th of February 2020, following that we have had 4 upsurges, but this we don't have an answer कि भाई क्या कब तक ठीक होगा. So maybe you have had a longer experience, if you could answer that. And second is, sir, I was very impressed by the data you have collected about the 35 patients whom you saw had poorer outcomes with certain comorbid conditions. One of them was smoking. In a few studies, and what I have clinically observed, sir, is that smokers tend to do better. Initially, we thought generally as COPD goes bad with smoking, asthmatics go bad in smokers. So we thought that COVID would go bad in smokers, and we found that they actually behaved better. This is an observation. We are collecting data on this as well at Mayo Hospital. So, sir, I don't know what it leads to. I would love to share that data with you, but this is what we observed, that a patient who's a chain smoker, if we ask them to take 4 to 5 cigarettes a day, their saturation starts improving. Now, this is something totally, I don't know, it's the nicotine receptors, or I don't know what it does. I don't know the mechanism of action. I've still to go into the literature, but this is how. And one of the studies I went through told that where they stopped the smoking, inhalational part of smoking, they applied nicotine patches to patients who were having severe COVID pneumonia, and they found a better outcome. This is published in one of the international journals. So this was just a little, and another thing that you talked about pre-existing interstitial lung disease. East Medical Ward and Mayo Hospital is also catering for rheumatology patients. So many patients presenting with interstitial lung disease associated with connective tissue disorders. Initially, we thought, oh my God, they are going to do very bad. Surprisingly, maybe because they were on immunosuppressants or hydroxychloroquine or methotrexate, very commonly used, they already on immunosuppressants, they generally we found, and we have actually published a paper on that as well in Annals of King Edward Medical University. I'll be sharing a link if you're interested. They did better. This was something, surprising, that we were anticipating that a pre-existing interstitial lung disease, on top of this fibrosis and COVID and thrombosis and all that, but they generally did better, maybe because of the concomitant treatment, which was not stopped, the immunosuppressors they were already having. So this was one observation I just wanted to share in Pakistan. Thank you so much.
Yes, if I may, that very, very educated comments. First of all, about the smoking helping with the COVID, I think you should immediately get in touch with the tobacco companies for a huge grant, because they would love to promote smoking in this time and age where smoking is banned everywhere. I think they will give you lots of money to conduct this study. That's number one. Number two, this is how business works. Number two, about the chronicity of the patient, I think we are in a stage of disease that we were experiencing in the first half of 2020, about the acute stage that we really did not know much about it, and therefore we lost some trust of the patients also, who thought that doctors don't do anything. And similarly, I think we are in the same mode of chronic stage of the disease at this time. And I think the body of knowledge is going to change as we learn more about it. And many studies have suggested that the only thing left is really steroid treatment, and so really nothing. I unfortunately can't add much to your experience. And I also have to tell you that your experience is probably the most prolific in the world, by the nature of number of patients, and by the fact that your radiologist of excellence is really almost like world renowned, and the fact that you are, I know that hours and timing is nothing. You guys are working 26 hours a day, mashallah. So I think the important thing is to collect the data, get the resources from the tobacco companies, and use it for research in these patients.
Professor Sarwat, my question.
Sure.
Okay, the same question that so many patients ask, that either our this fibrotic signs in the lungs or CRT will resolve or not. What is your idea? How much time they will take? Either we should keep on them on the steroid or.
Well, sir, my answer to them really is, well, that the patient will. My answer is something that patient will not understand, and the answer will be, we don't know. And we know that the patient don't want to hear we don't know, because the body of knowledge is such. But I think the Professor Bilqis's work and other people's work will make this clear, because the historic data is not long enough for us to tell them. But the good thing is, while you say that you don't know, you can also say, okay, if you pray hard enough, you will get better. And that actually resonates with our patient more than patients here in America.
Actually, sir, I'll fully support that.
Dr.
And
Javed
add
Naqvi, would you like to ask a question?
Sir, if I could just one short comment. I know I have taken more than the time I should have, but as Professor Sarwat has said, the more you pray, the better you get. It is actually the position of praying and the sajda which has been actually said to improve that one is proning, and the other is that sajda position, when it improves the circulation of the upper parts of the lungs as well. So it has actually been proven to benefit the patient, especially those who are desaturating. So we know about the various proning positions, 2 to 4 hourly change of posture to maintain the circulation, and the sajda position has been said to improve. And patients actually tell you कि नमाज के दौरान, हालांकि मैं बेड पे पढ़ता हूँ नमाज, लेकिन सजदे के दौरान मेरी saturation बेहतर हो जाती है. So this is actually, sir, something scientific, and actually this data should be collected, because many of the patients actually share this with us.
Yes.
Dr. Javed Naqvi, you want to ask the question? Dr. Javed Naqvi.
Gigi, I want to just pass a comment, because in our society, most of the patients are in state of denial. They don't even accept that they are suffering from the disease. And whenever they land up in the hospital, they are usually having most of the complications, and they are ending their lungs. They are very complicated and consolidated. But the X-ray chest is, as Dr. Sarwat has said, is one of the initial findings in the X-ray, but the clinical signs and symptoms usually they forego before the radiological signs set up. This was just my comment. the community should be made aware of the complications of the disease, and they should be sent for diagnostic tools as early as possible. Thank you.
And also, you see that what happens is when the patient come to the hospital in the, in a very late stage, and the patient dies, and the relative said, well, the patient बिल्कुल सही था, हम हॉस्पिटल लेके गए, बिल्कुल सही था, डॉक्टर ने मार दिया था. भाई आप अगर हॉस्पिटल पेशेंट सही था तो हॉस्पिटल क्यों लाए थे?
Yes, okay, they were very right.
Okay, there's a question.
Professor Dr. Sadaf Hussain, you want to ask the question? Professor.
Then there's a question by Dr. Qazi Taqweem al-Haq as well. Sadaf?
Assalamu alaikum, everyone. First of all, I'm Professor Sadaf Hassan. I'm working as a professor of physiology I'm Islamabad based. First of all, sir, I must pay you a huge tribute for such a beautiful talk on this burning issue and burning topic. And I was very much interested in listening to your lecture, though I am suffering from COVID, sir, these days, and it's been 10 days. And I was not even feeling like listening to just 1 hour talk, but it was so pertinent, and I was so much interested in it, sir. I have this is the sir 11th day. I have had the symptoms, sir.
वो एक और बता रही है जो published है international.
Ma'am, Salma, can you please mute the mics if you have the rights to mute them so that I can ask.
Yeah, I don't know who's causing this.
Asma Nudrat Zafar.
So, sir, I was having some symptoms, mild symptoms, and I was thinking that these may be due to change of weather and all that, and I have some allergy issues as well. But since they were lingering on, and I was not feeling well, and it was lasting about 48 hours, then I thought that it was high time, and then I went to my family physician, and then he said that now it's high time to go for your PCR. And sir, my PCR came positive on I think it was 15th of this month. And sir, after that, I was being put on some antibiotics and all that, and I was, fortunately, the symptoms were not strong, and they were not severe enough, and I was not put on the steroids. And at the same time, on the very first day, I was fortunate that I was started on treatment, and the first test that I was advised was to go for my HRCT. And sir, fortunately, that HRCT was absolutely fine. And after HRCT report and with the report of the radiologist, having the report of the radiologist, I went to my treating physician, and he said that if on the 6th day of this presentation, if HRCT is like this, so it's all good. So he put me on antibiotics, and he said that I should take the antibiotics for 5 days. And now, sir, I have completed the antibiotics. So my question to you is that what is the significance, and how much it is vital, or it is important, or is it indicated that as per the previous regime that we have to, after the symptoms and after getting the COVID positive and the PCR positive, there was previously a regime that we should be undergoing the repeat test, PCR test for after 2 weeks. So how much is it significant? Should I go for the PCR? Otherwise, alhamdulillah, throughout these 10 to 12 days, I remained symptom free. There were absolutely, alhamdulillah, there were no respiratory symptoms, although there was some element of, there was some discomfort like weakness and malaise was very much there, and
Dr. Saiba, what is
on couple of occasions,
your
sir, I had.
question?
So my
What is
question
it?
is,
Yes.
my question is, sir, what is if is there any indication that I should go after this 10 days, because in the coming week on 30th the second PCR is due? Should I go for the PCR or
Well, let me suggest to you, Dr. Saiba, that after this lecture, if you would consult Professor Bilqis Shabir, she's the expert in this treatment and management. I'm only in the diagnostics. So Professor Saiba can, I think we're coming to the end of our time, unless there are any other questions.
Dr. Qazi Taqweem, please go ahead with your question and then we'll finish the session.
Dr. Qazi Wasif?
Qazi Taqweem, Taqweem al-Haq. He raised his hand.
Mic off hai, mic off hai.
Unmute yourself, Dr. Saab.
Anybody ask the question, Dr. Uzma? You ask the question, Dr. Uzma?
If nobody is asking a question, may I ask a question, Dr. Sarwat?
Yes, of course. GGG, of course, Dr.
What is the rule of thumb? Which day should the X-ray chest be done, and which day should the CT be done?
Right. So really, basically, the question really is, the answer is that it should be a tool to make clinical decision to assess the status of the lungs based on the patient's clinical presentation or change in clinical signs and symptoms. I think it's really a kind of management tool if the patient gets worse or better for that matter when the patient is very advanced. So I think that's the time. It's suggested in radiology literature. I know that clinicians, of course, are the next to the patient and they have a better assessment. They can use the imaging based on their judgment, and we are ready to perform.
Thank you, Dr. Sarwat.
Thank you, G. Thank you.
Dr. Sadaf, Dr. Bilqis has answered that release the PCR after 10 days, and if it is negative, 2 tests are negative, you can break the isolation. Okay, if there is no question, Professor Kundi, we can close this session. Professor Kundi.
On behalf of,
thank you all.
I thank you, Dr. Sarwat. It was great meeting you. And as usual, it's a pleasure looking at Dr.
everyone.
Listening to her, and thank you, Mulazim Saab, Rashid Saab, and all the participants. We'll meet next Sunday, inshallah ta'ala. All the best.
Thank you, Dr. Bilqis.
Thank you so much.
Thank you very much. Thank you very much.
Sir.
Thank you very much, sir, for honor.
Thank you so much, sir. Thank you. Allah Hafiz.
Allah Hafiz ji. Allah Hafiz.
Allah Hafiz. Thank you, Dr. Bilqis. Thank you so much.
जी बहुत सारी दुआएं आपके लिए जी। अल्लाह हाफिज़।
Thank you very much. Allah Hafiz.